Dr. Bono, yes, thank you. So, Dr. Bono is a board certified neurosurgeon specializing in minimally invasive spine surgery. Dr. Bono treats patients with dealing with full spectrum of spine conditions, including degenerative diseases, vascular disorder, spinal injury, spinal tumor, and infections of the spine. Dr. Bono joined the Capital Institute for Neurosciences, part of Capital Health from Texarkana, Texas, where he was private practice and was on staff as Christos St. Michael Hospital and Christos St. Michael Rehabilitation, Wadley Regional Medical Center, and Els South Rehabilitation Center. Dr. Bono is originally from New Jersey, and he received his bachelor's degree in neurobiology from Rutgers University. He then went on to receive his medical degree at Jefferson Medical College and completed his neurosurgical residency at Thomas Jefferson University Hospital. Is a fellow of the American College of Surgeons. Dr. Buono has authored numerous books, chapters, and publications focusing on congenital intraspinal anomalies, technical consideration of stereotactic frames, and cardiomyopathy. Dr. Bono performs traditional and newer minimally invasive approaches to spine surgery. This includes performing axial lumbar interbody fusion and direct lateral interbody fusion, minimally invasive alternative to traditional fusion procedures. Its use of minimally invasive approaches means its patients spend less time in the operating room and recover more quickly. Dr. Bruno is a member of the American Academy of Neurosurgeons, the Pennsylvania Neurosurgical Society, the American Academy of Neurology, and the Society for Neuroscience. Thank you. Welcome, Dr. Bruno. And we have Dr. Matthew Toth. He has been working in the physical therapy field for 20 years. He graduated from Mercer County Community College as a licensed physical therapy assistant, PTA, in 2002. After receiving his bachelor's degree from Rutgers University in exercise science, he earned his doctorate in physical therapy, DPT, from the University of Medicine and Dentistry of New Jersey, 2010. Dr. Matthew has practiced in almost every area of physical therapy profession, but his passion is in outpatient orthopedic physical therapy. He has achieved board certified orthopedic clinical specialist from the American Board of Physical Therapy, specialties in 2016. He has worked for Capital Health for the past 18 years and also worked as an adjunct instructor in the PTA program at Mercer County Community College. So welcome, Dr. Matthew Toth and Dr. Lee Bruno. Thank you for coming.
Thank you so much. I appreciate that. So, in thinking about what I was going to talk about today, the subject that was given to me was back pain. And, for me to talk about back pain, it would take years. I had to kind of narrow it down and figure out how to talk about back pain since I've given this lecture before, but a bit more focused. So, I'm going to talk to all of you as if you were in my clinic. So when a patient comes to me in clinic for neck pain, back pain, whatever it is, we talk just like you're on a first date. If you're on a first date and things don't work out, you don't go on a second date. So on the first date, you're supposed to discuss everything. Explain to the patient what's going on so that they understand the problem. So, in this lecture, this little talk, we're going to kind of give you an overview of the most common problems that we have in the low back. If I talked about the thoracic spine, the neck, we'd be here for years. So let's narrow it down just to low back pain. So, and again, the approach is if you were a patient in my clinic, okay? So today, to break it down, we gave you the introduction talking about this is based on you being a patient in my clinic. We're going to talk about the industry, which most patients don't know about, what affects the outcomes and decision making when you see a doctor or a spine doctor. We'll talk about anatomy, how to understand the basics, which is very, very simple. Most patients think that when I start talking about anatomy, it's going to be over their head. It is not over your head. It's as simple as building Legos. Then we'll talk about diagnosis. That's the most important thing because patients go to, in my opinion, two different types of doctors. One type of doctor will say, I read your MRI report, showed some bulging discs. You got to see a back doctor. Well, that's not entirely true. When I read an MRI, I don't read the report. I read the MRI and I teach the patient how to read the MRI. So that's an important thing because there's a difference between saying, like many patients come to my clinic, I have bulging discs in my back. Well, if I teach them how to read their MRI, they'll understand better what that actually means and what it doesn't mean. Then we'll move on to treatments, which is the important thing, because most treatments for spine problems, and I'm glad you have a physical therapist here who's very experienced, don't require surgery. But guess what? How do I get paid? I get paid with surgery. So we'll talk about that's along the industry and how things over the years have kind of been corrupted. And my most favorite talk I've ever done, I started with a quiz. So I'm going to do a quiz on this one too, and you're going to like it. So at home, obviously, it's different doing this virtually than in person because in person, I can actually have people come up to the screen and point out things. So just kind of go through the pictures in your head. And of course, at the end, we'll have some questions. So let's talk about the industry. 80% of people, now these are rough numbers, but they're derived from our now famous AI. 80% of people will have back pain some point in time in their lives. Now, this is for low back pain. When you talk about neck pain, mid back pain, it's virtually 93%. That's about the quote. And everyone listening with the sound of my voice, unless you're 12 years old, has probably suffered back pain. And if you have back pain now, listen up. About 26% of people in the world have low back pain at any given time. And as far as doing surgery, there's two types of surgeries that we do for the spine. And really only two if you really oversimplify it. It's fusion surgery and non-fusion surgery. So non-fusion surgery is when you're trying to take something that's pressing off a nerve and remove it, called decompressive surgery. So if you got a pinched nerve, just like a splinter in your leg, I remove the splinter and then the pain goes away. Fusion surgery means you're joining one bone to another bone so they grow together and make one solid bone. And usually when we're doing fusion surgery, we're using screws and rods. And the prices for screws and rods is huge. So the spine industry has grown and grown, and now it's over a $20 billion industry. Insurance reimbursements are lower for the doctors in the hospitals. So what do the spine surgeons do? Well, instead of doing the cheaper surgery, everyone gets a fusion when not everyone needs a fusion. In fact, very few do. And if I've experienced that in my own practice, About last year, I was out of work for about a month. I was in a car accident. Now, don't worry, I'm fine. And in that month, I had a few patients who really, really needed spine surgery and couldn't wait for me to come back. So I said, well, I'm going to send you out to a few people that I know. Now, these were two that come to mind were simple disc herniations. You don't need a fusion. It's a simple little surgery and it's done as an outpatient. But both of those patients came back and complained and said, the doctor said I need a fusion. Why is that? What's wrong, Dr. Bono? I said, well, you don't need a fusion. I explained why. And it's kind of shocking. So, everyone hearing this by the sound of my voice, you have to do your homework. That is the purpose of this talk today, to open your eyes and teach you something. Bigger surgery equals more money. And where there's opportunity for corruption, everyone gets corrupt. Okay, now let's start with the basic. Pretty simple. This is kind of a boring drawing. Looks like you're in day one of human anatomy or in college or medical school, but I'll just go over it briefly. Can everyone see my little arrow? So this is a side view of the spine. These little square things are the bones. You could see these are the bones. That's pretty simple. The yellow stuff is the nerves. The nerves in the low back go through the center of this little tube here, through the center of the tube, right here. This is a cross section. And then each little nerve coalesces to form a bigger nerve, which goes out each one of these holes to go to your leg. And that's basically it. Now I'll show you some pictures about how to read an MRI. This is what I do with my patients. And so if you see somebody, some kind of doctor about your condition, and they don't show you how to read your MRI, that's bad because it only takes 30 seconds. Here we go. Ready? This is an MRI of your lumbar spine, just like I would tell you in clinic. This is a side view. So we cut you in half. This is your back. This is your belly. These little black lines here are the discs between the squares, which are the bones. The nerves go through this tube right here, this big giant tube. And the tube ends down here naturally. The gray things are the nerves. The white stuff is spinal fluid or water. This is a cross section over here. So here's the belly, here's your back. This is the right side. This is the left side. It's switched on an MRI. This is the disc. All the nerves are going through the center tube, cut in half here. These little dots here, the nerves cut in half, and they coalesce to form a big nerve right here, leaving this hole to go to your leg. Done. That's it. So, for example, on this patient here, I've had many patients come in with normal MRIs, and the radiologist will say, well, got a disc bulge. Yes, I have a disc bulge, Dr. Bono. I have a disc bulge. That's why my back hurts. Okay. This right here, that's a disc bulge. I guess, yeah, you could say it's a disc bulge, but there's no compression of the nerves. There's tons of water in this tube, like a hallway. So, no, that's not a problem at all. And yeah, you could call it a disc bulge, but unless you're 12 years old, everyone's going to get a little disc bulge in their life, part of getting gray hair. Now, a CT is even easier, just shows you the bones. Here's the squares, those are called the vertebral bodies. The spaces are where the discs are. And the nerves, again, go through this tube. This is a pretty normal CT. These bones in the back are the ones you can feel in the middle of your back, especially if you're a skinny person. Those little bumps, that's called the spinous process. Here's a little cross section. Vertebral body, all the nerves go through the center hole, spinous process. Pretty simple, right? Okay. Now, we'll talk about some common causes. I broke this up so that we'll talk about diagnosis first and then take a little bit of a pause and then talk about treatment because if not, it becomes too noisy. And it's the way I do it with patients anyway. First, you examine the patient, and then you review their imaging studies, teach them how to read it, and then you talk about diagnosis and possible causes. So, all right, here's an actual patient. This is an actual patient. This patient came to see me with low back pain. Okay. Woman with low back pain. And she brought in x-rays. And I said, you had a fusion. She said, yeah, I had a fusion, but I still have back pain. See the screws? Anyone see the screws? And then over here, the picture that's all the way on the right, there's an inner body cage. So someone took out the disc and put a cage in there. Someone did a fusion. I didn't know why because it didn't make sense to me. So I said, why don't you come back next time, but bring your MRI you had right before you had surgery. So this is her MRI before surgery. There's no pinched nerves. The canal is wide open. Here's all the nerves. And all these discs look great. Why did she have a fusion? Huh. I don't know. But that wasn't her problem. Her problem was she had sacroiliac joint disease because she's a mother of three. So they had the wrong diagnosis and did a fusion on her. I don't know why. And now she has to have another injection or sacroiliac joint. But this is an unnecessary surgery right here. So the doctor never bothered to explain her, by the way, your MRI is normal. I'm going to do a fusion on your back. Be careful. It happens all the time. I see it all the time. You may think that you're standing in front of a doctor at the clinic and all they're going to do is be honest with you. Well, think again. So here's a patient. Patient comes, a lot of you probably had this before. They say, I have sciatica. I got leg pain. It kills me. I can't sit. So, next step, let's examine the patient. Pain is mostly on the right side of the back, goes all the way down the leg. So I lie them down on a table, raise their leg up, and they want to punch me in the face because the pain is so bad. So this is called a straight leg raise. It's part of the exam. People also calls it a Laseg sign. So what you're doing here when you raise the leg, it stretches the nerve, the sciatic nerve that goes down your leg. And if there's something in your back, it'll kind of bowstring it and cause pain. So after the examination, we looked at the MRI and I said, let me teach you how to read an MRI. Here's the discs, blah, 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 blah. Here's the center canal. Can anybody see where the disc herniation is? And they say, oh, yeah, look at that. Yes, you have a big disc herniation right here. Nothing here, nothing here, nothing here. The rest of your spine is normal. You have a disc herniation. Look, on this picture, this is the axial image. So it's a cross section, as you guys call it. Here's the center canal, giant chunk of disc there. This is the right. Yes, I'm not weird. And this is the left. So they have a big disc herniation. And I say, okay, that's the problem. And there's ways to treat it, many ways to treat these things, disc herniations. Then we talk about the philosophy of why we should do this in your case and whatnot. If the patient has obviously a neurological deficit, which means foot drop, bad numbness, paralyzed leg, you're more apt to do surgery. All right. Now, this is pretty typical, and I'm almost guaranteeing you somebody watching these slides right now has this. You can't stand up. They can't stand up straight. They feel better when they sit. And I ask them, when you go to the grocery store, do you lean over the grocery cart? And they say, yeah, I do. I lean over the grocery cart. Well, that's called neurogenic claudication. The reason we call it neurogenic claudication is because it makes me sound smart. So neurogenic claudication is simply, I can't stand. When I stand, I get pain into my butt, down my legs. And the reason for it biomechanically is because when you stand, your spine arches back and the ligaments back here, kind of like rubber bands, push in. Now, if you were to bend this the opposite way, this way, the rubber bands flatten out and you feel better because the canal opens up. It's a little bit difficult to describe that without having a video, but I'm not very good at videos and these kinds of things, so I just left it at that. So I'll give you another example.
In different ways, just based on the way our state laws work, but we are absolutely aligned in promoting as much access and coverage as possible.
Can everybody hear? We good?
Yes, yes.
Oh, okay.
Yes, we're good, sir. Thank you.
So this is actually a real person taken over time. This is when they were younger. This is when they're probably 40s. And you can see the canal's getting more narrow as time goes on. No, this doesn't happen to everybody. And now they present with neurogenic claudication. I can't stand up, hurts in my butt, down my legs, because the tube here is obviously narrowed. And if you could see carefully here, the nerves are kind of nice and straight, like cutting off a woman's ponytail. If you had straight hair just hanging there. Then they start to curl up a little bit, and now they're clumped up here. I know the picture is not that great, but they're straight here, but clumped up here because they're pinched. So again, if you bent forward and sat or leaned forward, this ligament flattens out and opens up the tube. But for something like this, you could try epidural steroid injections. We'll talk about that a little bit later. Or you could do surgery or physical therapy. Again, neurogenic claudication. You feel better when you sit. See, happy guy right here. Feels better when he sits. And when you have what's called a spondylolisthesis, again, I'm using a fancy word, makes me sound smart. That's where the bones don't line up. See this bone slipping forward? Well, this bone's slipping forward and making it narrow right here. So if you lean forward, it'll flatten out the ligament and you'll feel better. Interestingly enough, they came out with a treatment about 15 to 16 years ago called an X-stop or an inner body device. And it's a device where you put a spacer right between these two bones here, right there. And it was designed to push this bone up and flatten out the ligament. But what happened over time is that little spacer they would put in here just eroded through the bone and they ended up having surgery anyway. But that surgery is still done today. And it's done by people who are not certified as surgeons. It's done by pain management doctors and anesthetists who do these procedures, and then I have to take them out. But hey, you're putting in a device, you get the bill for it, and patients just eat it up. Mechanical back pain. Some of you have this. It's when you're twisting, you'll feel a sharp pain in your back. There's many causes for this, and I can't get into all the causes now. You could have problems with the certain joints in your back called facet joints. You could have, it could be caused by SI joint disease, blah, blah, blah. But sometimes you could have a fracture. So I will see a patient occasionally and I say, you've had back pain for how many years? Oh, 20 years. And I went and saw my whatever kind of doctor. And I look at their spine, looks pretty good. I don't see anything bad on there. I say, let's get a CT. CT shows the bones. Look what they missed through all those years, a fracture right there. Sometimes it's due to trauma, and sometimes it's due to a congenital abnormality. It means you were born with it, born with a thin pars. This is called the pars. You can imagine if this bone were broken, there's nothing preventing it from sliding forward. This bone can't slide forward because it's locked into position by this joint. So we find the fracture and say, you got a fracture? Well, how are you going to treat a fracture? It's not going to heal. It's been there for years and years and years since you were born. Probably going to need surgery. If you do physical therapy, you still have a fracture. If you do an injection, you still have a fracture. And then a lot of people buy those heaters hang-ups, those inversion tables. I love seeing that commercial because it shows the discs in someone's spine and all the water going back into the discs. Well, that's not true. That doesn't happen. All right. So here's a patient, very common. I have back pain. I've seen 6 other physicians. No one can help me. I've had 6 epidural steroid injections. That's when they inject steroids into your back around the nerves. I've had PT twice for a total of 6 months. No medications help. And then I saw 2 doctors who want to do a fusion. Okay, this is a real patient. Real patient. Okay. So I love this patient. I remember her. She was great. We looked at her MRI and taught her how to read it. And well, you don't need a fusion. Your canal's open and there's no signs of instability or fracture. Huh. So I got a CT and it shows that she has a congenital long transverse process right here. This is an abnormal bone right here that is grinding onto her sacrum. That was the cause of the back pain. She doesn't need a fusion. So you got two choices, I said to her. Well, we can go and do surgery and cut out that bone. Who wants to have that done? Or you can just do an injection in here. And that's what we did. And it gave her 2 years of relief. And after that pain came back, you got an injection again, no surgery. So she gets an injection every 2 years, no surgery, no fusion. That's the cause, called Bertolotti's syndrome. It's not that uncommon. Here's a pretty classic one. This is the number one misdiagnosis for low back pain. Number one misdiagnosis. Typical patient is a woman, 3 kids. She has back pain, just wants to get better. We look at her pictures and everything, not bad. Then we do this test. Lie them down on a table, put your foot on your knee, and press down on the opposite knee and the hip. Then they'll say, that hurts my back. Well, that's called a Patrick's test. It's a sign of either hip disease if your hip hurts, because when you're doing this, you're moving the hip joint. The knee's not moving, just the hip joint. And you're moving your sacroiliac joint. So her diagnosis was sacroiliac joint disease. We sent her for a CT, and look, these are the sacroiliac joints. This is the sacrum. That's the ilium. This one's okay. This one looks terrible. We also sent her for what's called a nuclear medicine joint scan. My absolute favorite test in the entire world. Because patients will come to me with arthritis or some kind of condition. And if I say you have arthritis, not too often they will get mad at me and say, I don't have arthritis. I have a bulging disc. Or everyone said I have bulging discs and I need surgery. No, you have arthritis. So a bone scan, they inject this radioisotope in your arm and you wait around for a couple of hours. Then they take a picture of your body. So this woman has arthritis. Anything that lights up shows arthritis with the exception of your sternum. She has arthritis in both shoulders. This is the left shoulder. That's the right shoulder. A little bit in both hips and both of her sacroiliac joints. So what did we do in we sent her for orthopedic evaluation for her shoulder and then gave her sacroiliac joint injections, which usually, in my experience, last 1 to 2 years. Sometimes it's permanent, but I wouldn't know because the patient never came back to complain. So, yeah, you don't need surgery for that. Okay, now here's what everyone will have. If you don't have it, God bless you. You're amazing. This is the most common complaint that I have in clinic. And in fact, I would estimate that 80% of my patients come in with this complaint. My back hurts. It's worse in the morning. It's worse with long car rides. It's worse when it rains. And I look at their hands as we're talking, and they have crooked fingers or little bumps on the end of their fingers called Heberdin's and Bouchard's nodes. Again, cool sounding words that make me look smart, but obviously they have arthritis. So they have arthritis. And then they usually come in with a ton of pictures saying, obviously, because the radiologist read it, that you have a bunch of bulging discs and you need surgery. No. So if you look at this picture on the left, here's a disc. There's this, the gray is bone. There's a big bone spur here, big bone spur here, bone spur here. That's arthritis. And there's bone spur here, bone spur here. And on the x-ray, bone spur, little bone spur there, and bone spur, all the way on the right. I don't know if you could see the pictures on the right, but those are huge bone spurs. So I show them, you have bone spurs. The fancy word is spondylosis. That just means bone spurs. But again, I use it because it makes me sound smart. So it's arthritis. And they say, well, can you remove the bone spurs? No, they'll just grow back. I would love to, it'd be fun, but you don't need that. You have arthritis. Here's a bone scan. This patient was very mad at me. This is a normal bone scan on the left. A little bit of arthritis in the right shoulder, pretty normal on the left. On the right, This patient has arthritis, was mad at me because they had left knee pain right there, wrist pain. Oh, someone said they had carpal tunnel surgery. This patient had carpal tunnel surgery for wrist pain, never had numbness, and never needed carpal tunnel surgery because they have arthritis in their wrist and their fingers and their back and their shoulder, all over the place. See the spine here? That's arthritis everywhere. So I can't do body transplants. And this patient, we'll send him to rheumatology and a knee doctor and get him on the right medications to help with their arthritis. Arthritis is only helped with two different things, two different categories, two, unless you have such a bad joint that it needs replacing. So the two categories are physical therapy and arthritis medication, depending on what kind of arthritis it is. It could be psoriatic arthritis, rheumatoid arthritis, osteoarthritis, whatever. We tailor the medication based on what kind of arthritis it is and where it is. Okay, now the treatments. I probably jumped ahead already in this talk, but this is the important thing because some of you are saying that you have some of those things already. So let's talk about treatments. So arthritis, since I see that the most, even though I am a neurosurgeon supposed to do surgery, people are just sent to me with pain. So people with arthritis have morning stiffness, joint pains, worse when it rains, worse with prolonged sitting, better with movement. So they'll get up in the morning and say, my back is stiff, my joints are stiff. But after I brush my teeth and move around and have a cup of coffee, it eases up a little bit. And then NSAIDs are non-steroidal anti-inflammatory medication. So anti-inflammatory medication, arthritis means inflammation of the joint. So if you treat the inflammation of the joint with an anti-inflammatory, whether it's steroids or non-steroid pills, NSAIDs, then they'll feel better. Now, why is it worse in the morning? And why is it worse when it rains? Well, low pressure systems bring rain, and that changes your. It's hard to go into because it would take too long, but it inflames your joints more. The other thing that inflames your joints more is what people get prescribed for arthritis, which is opiates, oxycodone, those things, those painkillers that are DEA controlled. Well, when you take those, they release histamine, and histamine causes inflammation of your joints. So if you go out to one of these bad parts of town somewhere and saw a heroin addict and follow them for a few years, by the time they're 5 years into the use of heroin, they're so crippled up with arthritis they can barely move. So everyone gets arthritis at some point in time, except for one person. I saw a woman who was 101 years old, not a pain in her body. She saw me because she had a little confusion. And other than that, she was sharp as a tack. And the MRIs, they got an MRI of her whole body, was completely normal. So I don't think she was human. Again, arthritis. Joint scan to convince people who are mad at me you have arthritis and you can see it. And it's pretty neat to see. Then when I show them this, they're like, oh, that's not why my knee hurts. Oh, that's why my knuckles hurt. That's why my wrist hurts. So again, the treatment, motion, physical therapy, opiates are bad. If it's bad enough, like this person, I'll send the patient to a rheumatologist or send them out for blood work to find out, do they have rheumatoid disease? Do they have ankylosing spondylitis and HLA-B27 positive? These are blood tests, things like that. Surgery for arthritis? Well, let's just take a pause there for a second. I categorize patients into three types to predict outcome if they're going to have surgery. The first type of patient is a young 18-year-old, no problems with their body at all. They're perfect, but they have a splinter in their thigh, which hurts. That's a type A patient. I take out the splinter, they feel great, there's no pain, nothing else hurts. A type B patient has a splinter in their leg they're seeing you for, but they also have arthritis all over their body. So you have to tell them, listen, I'm going to take the splinter out. Your leg's going to feel better, but you're still going to have arthritis. It's important you know that. I can't cure arthritis. I can treat it with your rheumatologist, but you're still going to have pain everywhere. The third type of patient for outcomes is someone who has the splinter in their leg, arthritis, and heart disease, heart failure, COPD, renal failure, everything else. Their outcomes are going to be a heck of a lot different. Again, arthritis, what's the principle of treating arthritis? And it's important you know this. So arthritis is like a fire in your joint. So my son and I like to make fires outside, little campfires. So if you started the fire like this on the left and then poured 50 gallons of water on it, you would just see charred logs. If you let the fire burn overnight, you're just going to have ash. So if you don't treat your arthritis, the difference between the clone of you in 10 years and someone who took arthritis medication is going to be vastly different. Arthritis will burn out your joint if not treated. I hope everyone remembers that slide. Sacroiliac joint disease, we discussed as the number one misdiagnosed cause of back pain. It can happen in men, but it's mostly in women, especially women who've had children. God bless you all. Because you carry the baby in your pelvis and you've had a few children, or maybe even one big baby, and it stretches the pelvis and puts stress on these joints and they become arthritic. So you can do a little SI joint injection, or you can do this, a sacroiliac joint fusion. Let me see, which one reimburses more? Which one would I get paid more for? Well, of course, the fusion. But who wants this? I don't do this because I don't think it works. I've seen a lot of patients who've had this done, and none of the patients ever had great results, ever. So I don't do that. I just send them for SI joint injections, and they repeat it throughout the every couple of years or so. So when people try to sell you this, wouldn't you rather just get a shot in your sacroiliac joint? Please. All right, disc herniations. Another common thing that I see, but people really don't know the natural history of disc herniations, which is really important because it guides how we treat them. So obviously on this MRI, you'll say, now that you know how to read MRI, there's a big disc herniation right in the middle there. That's going to pinch a nerve and it's going to cause pain down your leg, numbness, maybe some weakness, and the pain can be excruciating. So 86% of disc herniations, the vast majority, resolve inside of 3 months. So unless you have a bad deficit, that means either horrible, horrible pain, where you cannot live without being on morphine or put into a coma, or if you have a deficit like a foot drop or paralyzed leg or bad numbness, whatnot, then we want to buy time because we know that 86% will go away in 3 months. How they go away? Well, they kind of shrink and little macrophages eat it and stuff like that because your body's smart. Your body's made by God. And so that's all that there is that need to be said. So it also will depend on what the disc looks like. If the disc is enormous, it's less likely to go away. If it's small and light in color, that means it's soft. If it's darker in color, that means it's harder cartilage. So you can kind of predict reasonably whether someone has a ginormous disc herniation that's really dark in color and they have a foot drop, well, they're going to have surgery. If not, if it's small and they say, well, the pain's pretty bad, it's only been a couple of weeks, then we'll try an epidural steroid injection. An epidural steroid injection is only indicated for a pinched nerve. That's it, a pinched nerve, a narrowed tube that you see right here. This is pretty obvious. I've seen thousands and thousands of patients who've had multiple epidural steroid injections with an open canal, and they say they never helped. So he said, well, let's try them again. No, 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 no. Read your MRI. So epidural steroid injections will buy us time because they'll make you feel better. It doesn't make the disc go away. It's not acid. It's not Roto-Rooter. just an injection. So the nerve who's really irritated because it's been beat up by this disc feels a little bit better, and you're buying time. Physical therapy, we'll talk about that in a second. Time is important. Wait if you can. Never do surgery on a patient who continues to get better. If a patient says to me, I'm still hurting, but I'm 50% better than I was last week, I'm not doing surgery on you because 86% resolve and you're getting better. Traction? Now, in the old days, they used to do traction on this, but to do real traction, you'd have to put rods into your femurs. You don't want that. So, no, traction doesn't help to push this disc back in. Hot or cold? People say, should I use hot or cold? I don't care. Whatever you like. There's no real good science between either. So, whatever makes you feel better. I had an old Italian woman, just a gem of a woman, and she used to rub olive oil all over her joints. She said, can I do that? I said, I don't care if you want to turn yourself into a salad. That's fine with me. I know it's not hurting you. Just get the cheaper olive oil so you don't spend a lot of money. She actually said that. So why don't I order physical therapy for a disc herniation? Well, insurance companies want me to send patients with disc herniations to physical therapy, and it says that in some of the literature. But if you have a disc herniation, a disc is like a jelly donut. And this is what I tell my patients. So if there's a hole in the donut and you squish the donut, the jelly is going to come out, just like here. That's a disc herniation. Here's the outside bread of the donut. There's the jelly, and it's squishing out. So if someone said to you, if I squish the donut, that'll help, I'd say you're ridiculous. You're going to make it worse. No. In the old days, it was just rest and relaxation. So epidural steroid injections don't cure disc herniations. Physical therapy doesn't cure a disc herniation. Time and God and maybe surgery will cure a disc herniation. But be wary if you came to see me and you had pain in your arm, and I said, okay, let's get an x-ray of your arm, and your arm was broken, and I said, go do physical therapy, you would run out of my office screaming because that's ridiculous. You treat a broken arm with a cast or rarely surgery. So just remember a disc herniation is a jelly donut. So spinal stenosis. This patient has some spinal stenosis. They've failed everything. I'm not going to do surgery on a patient unless they failed physical therapy, not for disc herniation, for spinal stenosis. That just means the ligaments kind of sticking out a little bit. There's a bone spur right here, and the canal is a little bit narrowed. So for spinal stenosis, you try physical therapy first. You could try epidural steroid injections. And if everything else fails, you do a laminectomy or what's called decompressive surgery or whatever you want to call it. All that means is you just, like this cartoon, you remove the roof here to make more room for the nerves inside. You take these and you get rid of them. You don't need the bones back there. There's big, thick paraspinous muscles that protect your spine. So people say, well, am I going to get injured? Am I more apt for risk of injury to my nerves or my spinal cord? Well, first of all, your spinal cord ends all the way up here at L1-2. There's no spinal cord down here, only nerves. It used to be down here when you were a baby, but then it shrinks up here as you get older. So no, you will not be injured if you have a laminectomy. Now, for a fracture, here's that fracture we saw. This patient is a real patient, had two fractures, one here and one here. Well, this one's separated, and we did something called flexion and extension x-rays where they're bending, and this one moved. This one didn't. Then we sent them for a bone scan, nuclear medicine joint scan, and this one was lighting up and this one was quiet. So we just fixed this. Patient had no pain afterwards, but yet has a fracture they were born with here. But I didn't treat that fracture because it wasn't causing symptoms, and I did a workup to prove it. And this is a spinal fusion. So there's screws in the bones, a little spacer in between, because you have to fix the fracture. It won't heal on its own. This one won't heal, but it's not causing pain, so I'm not going to touch it. But that's what it looks like after you have a fusion. When you do a fusion, you got two options. You can do it the old way or the new way. The old way is open fusion, which most people do. And actually, most universities do because it's a little bit harder to treat MIS surgery in a university. At least that's what I'm told. So I only learned minimally invasive surgery after I finished my training at Jefferson. Nonetheless, open surgery means you have to make a big incision like this, but MIS surgery just means minimally invasive surgery or minimally invasive spine surgery. It's a smaller incision, and you don't have to scrape all the muscles off the bones. It's a faster surgery, it's faster recovery, less blood loss. And since it's faster, less chance of infection, lower complication rates from anesthesia, and the like. The approaches for minimally invasive surgery are many. The old way, this is someone's body cut in half. This is kind of boring, I know, but just get through it because the fun part's coming. You could approach the spine from the front, which is called an anterior lumbar interbody fusion. And then all your guts are in there and two big blood vessels, giant blood vessels. So who wants that going through your belly? That's not fun. You can go through the back, posterior or translaminar interbody fusion, but in your way is the nerves. I don't want to risk nerve damage. And this is actually a misdrawing for an OLIF, but you can go through the side, which there's actually no organs there. But if you go through the side there, you miss all the organs, you miss all the nerves, and it's a safer approach. It's called a DLIF, XLIF, or LLIF, whatever you want to call it. It's minimally invasive surgery, and it's pretty cool. So here's an example. Here's all the organs, all your gut stuff. Here's the big blood vessels, missing all those. This is the psoas muscle. It says PS. It's just a muscle. So you go down there bluntly. There's no cutting of anything. Everything's kind of pushed aside, and you separate the psoas muscle, but you don't cut it. It's like sticking your finger through someone's ponytail. So you're not cutting the hairs, and then you dock onto the disc, and you could place a little interbody spacer in there and fuse it. And that's what it looks like actually in the operating room. It's just a little tube right there. It's pretty cool. The goals of surgery are very important. So it should be a philosophy that less is more. Okay. You don't want to do, I don't want to solve all of your problems if I can't solve all of your problems. I want to do the smallest amount of surgery with the best and safest results. I don't do the biggest surgery so I can make the most money with weaker results or higher risk, which is some people's goal. And I'm trying to teach you and tell you, please be wary of that. I love that cartoon. All right, who's ready for the quiz? I hope your palms are sweating. All right, so again, just to go over this briefly, this is a side view of your back, okay? This is an MRI. These little lines are the discs, okay? The nerves come through this center tube here. This is basically a normal MRI. I will tell a patient, okay, I'm going to point to a disc. You tell me if it's good or bad. And they'll say, good, 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 good. This one's a little bit dried out and squishy, but it's not hurting the nerves. So this is a pretty good MRI. Okay, quiz one. These are real patients. I have back pain and they said I have bulging discs. A lot of patients will say, my discs are bulging at L4, 5, L6, and L7. And I can't laugh because there is no L6 and L7, but you just realize now I have to do some more teaching, okay? So here's the patient right here. They have bulging discs. Well, I'll show them, yep, that's bulging a tiny bit. That's not causing your problem. That's bulging a tiny bit, not causing your problem. What should we do with this patient? Well, they probably have a little bit of arthritis. We have to finish the workup. Find out why they have back pain. After the examination, is the back pain in the morning? Is it at night? Is it withstanding? Things that I'm asking for, like, are you unstable? Do you have arthritis? And then we'll pick. Does this patient need epidural steroid injections? Please, all of you, be shaking your head. No, no, there's no pinched nerves in here. None. The canal's wide open. So if the doctor says, after you now know how to read your MRI, if they said, let's try epidural steroid injections, just run out of the office. Physical therapy? Yes, physical therapy helps everyone. Even if you have cancer, if you have physical therapy, it'll make you feel better. So physical therapy, with the exception of doing it for a broken arm or a broken back or a big, huge disc herniation, is a great thing. Surgery? No, this person doesn't need surgery. I don't see anything on these films. After the completed workup of x-rays, bending, bone scan, blah, 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 then we'll probably try physical therapy first and some anti-inflammatory medication, either over the counter or prescription things like prescription NSAIDs like meloxicam, celecoxib, things like that. All right. Again, this patient says, I have back pain. They said I have bulging discs. Well, we have to go through the films. Do you see any bulging discs? Please shake your head no. Okay. No, there's no bulging discs. But I say, look at the discs here. Tell me if anything's abnormal. And they point to this. Whoa. Yeah, there's a bone spur here. Bone. Oh, that's arthritis. Okay. We go to physical therapy. We go to NSAIDs. You don't need surgery for that. And you don't need epidural steroid injections because there's no pinched nerves and there's no bulging discs. So, no, just the most common thing that I see. You have arthritis, so treat the arthritis. This patient, I have back pain. They say I have bulging discs. Yes, you certainly do. Now, in this patient, like we talked about before, unless you have a real bad 10 out of 10 pain and can't breathe and don't have like any kind of problem with your leg, like a foot drop or numbness or weakness, then we could try non-surgical treatment and try to wait it out. 86% of disc herniations go away inside of 3 months. So we'll try everything. But if nothing works, or if you have some kind of a problem with your leg, it's not functioning right, you don't want to wait a long period of time if someone has a paralyzed leg. The longer you wait, the less likely it's going to come back. That's kind of like common sense. So we would do a little surgery. And with the surgery for this, we would remove this chunk of disc, not the whole disc. They say it's a discectomy, but it's not a whole discectomy, just the chunk here. And I tell the patient, don't forget, you got a hole in your donut. So after the surgery, be careful what you do for about 4 to 6 weeks. Watch your bending, twisting, and heavy lifting. So this surgery usually takes about 15 minutes. As an outpatient, you go home the same day with a tiny little incision like that with some glue. I'm not selling surgery, but it's not a big deal. Here's another patient. This was actually a real patient, but that's not the photo of him. But this is the real patient's MRI. This patient came to see me, said he had bulging discs, and two other doctors said he needed surgery. One said he needed a fusion. I'm looking at his MRI and I'm saying, wow, that's a great looking MRI. And hopefully you out there are looking at his MRI saying, yeah, it's a great looking MRI. So he said, I want epidural steroid injections. I said, you don't need epidural steroid injections. It's for pinched nerves. You don't have any pinched nerves. He got so angry. He started throwing stuff. I said, listen, calm down, calm down, calm down, calm down. Let me go through the MRI again with you. Didn't want anything to do with it. Stormed out of the office. So some people, it's rare. I'm just trying to teach you what's wrong with your back. I can't lie if I'm showing you the problem or lack thereof. So it's very important that if you see a doctor, they go through everything in particular with you. If you've had imaging studies done, they teach you how to read it. Now, not all doctors know how to do that, especially if it's a primary care doctor, but it could be your specialist, orthopedic surgeon, spine surgeon, neurosurgeon, whatever. If they have an MRI, they better take time to go with you and review each little picture to show you how to read the MRI and what the problems are or are not. And if you have, just like I was talking in the beginning of this speech, I said, it's like a date. If you don't connect with the doctor, get a second opinion. There's tons of us. And just like people, we're not all created equal. Not all of us create equals. There's great doctors and there's terrible doctors. So there's just no bad patients. All right. Questions?
Thank you, Dr. Bruno.
Sure. Any questions at all?
I have a question, sir. Thank you so much for this educational section, sir. My name is
Sure.
Toyin Alumole. I'm in Minnesota, and this is very, very helpful.
Good.
You gave us a lot of takeaways, and I've had surgery before. I believe the surgery I had was a laminectomy.
Okay.
Uh, And I still have is the lumbar laminectomy. That's what it's called. I remember.
Mhm.
But I still have pains. And they suggested another surgery. And I said, no way. I'm
No,
going
no,
to
no, no.
live with
So
this.
your next step, my darling,
Yes,
your
sir.
next step is for your
Thank you.
doctor to find out why do you have those pains, not guess and just say you need surgery. So if it's only back pain and not leg pain, which I'm thinking it is, correct?
Yes, sir.
Yes, it's only back pain. It's probably arthritis in something called the facet joints. So you would need x-rays of you bending your back, and that joint scan will show you where that pain's coming from. What if it's your sacroiliac joints? What if it's the facet joints? There's different parts of your spine that can cause pain. So if it's not leg pain, you don't need epidural steroid injections. You don't need a laminectomy. It's probably one of the joints, 100% one of the joints. So you have to find out which one. To do that, get a joint scan. It'll show you so you can see it because you saw those joint scans. A 3-year-old could read a joint scan. It'll show you a white spot right where your pain's coming from. And then guess what? If it's a bad facet joint, you can have a facet joint injection or something called a facet joint neurolysis. That's where they burn the little tiny nerves that allow you to feel that joint, not the nerves that go to your leg, the little tiny nerves that allow you to feel that joint. So the joint becomes numb, your back pain's gone, and you're happy. Or if it's your SI joint, your sacroiliac joint, which it could be, just get SI joint injections, but you need a joint scan first. Nuclear medicine joint scan.
Okay.
Thank you,
Yeah.
Dr. Bruno. There's a question here that you mentioned foot drop with herniated disc. Can a 76-year-old woman still get surgery or just live with the pain?
No, no, you can have surgery. I've operated on people well into their late 90s. As long as you're healthy enough for surgery, age doesn't matter, and it's not just a statement. Age does not matter. It's health that matters. So, no, you're still young in your 70s.
Thank you, Doctor.
Sure.
There's
Good
another
afternoon,
one.
Doctor.
The question, good afternoon, Doctor.
Yes, sir. Good afternoon. Yeah, good
Excuse me,
afternoon,
just
Doctor.
one at a time, please.
Okay.
One,
Thank you, Doctor. I have
Sure.
the question for you. Can I go on?
Go ahead.
Okay, ma. Thank you. Thank you, Doctor, for the well-explanatory teaching about pain and prevention. I have this pain on my wrist. It's an intermittent pain, and I don't know what to do about it. That's one question. And the other one is it very good to be using all this NSAID and ibuprofen every day for when you have a joint pain?
Well, if you're using over-the-counter stuff, you're going to have to take a ton of pills throughout the days because they're not very long lasting. So if you have wrist joint pain and it hurts when it's raining and
Yes.
it aches on, yeah, it does. So you know what the diagnosis is. What is it? It's arthritis.
All
So
right.
you should be on arthritis prescription medication, 1 pill a day.
Because my
Not
doctor was like saying you could use something like ibuprofen or Aleve. But
well,
that's
you can, but it doesn't last very long. The prescription medications, such as
You stop here.
celecoxib, they last for 24 hours. So
yes.
you take 1 pill at dinner, and only when you're having a bad day, 1 pill at dinner, and you're good all day.
Okay, thank you.
Sure.
There's a question that say, can you please go back to the jelly donuts briefly and
Sure.
best course of action?
Yes.
Good afternoon now. Can I speak?
Oh, not yet, please.
Go ahead. And did you have a question about this?
Yeah, it says, can you, okay, you go back to jelly donuts briefly. What is the best course of action?
So if you have, this is a simple disc herniation, just like here, okay? It's a disc that's squirted out and it's pinching on a nerve, okay? So if the disc, since 86% of these disc herniations go away inside of 3 months, if it's improving, leave it alone. But while you have the disc herniation, I always tell patients, you wait till the symptoms completely resolved and then wait 1 month before you do regular stuff. In other words, don't lift trees and heavy things, watch you bending and twisting. But if you don't have a deficit and you just have pain and it's been, let's say, 6 months, then nothing's helped, still have pain after 6 months, then you can have surgery. The surgery for this, like we explained, it's about 15 minutes. You go home the same day. All you're doing is taking out this little tiny piece right here. And then we reach in here to make sure there's no loose pieces of jelly that are going to squirt out later.
Okay, thank you.
Sure.
Shola.
Good afternoon, sir. Thank you,
Hello.
doctor, for your explanation. I
Yeah.
had a disc herniation, and I have took injection, epidural injection 3 times. And it's like when I take it after 3 months, it goes away, it come back again. It goes away and come back again. So the last time I took it, I almost passed it. I almost paralyzed. So I said, no, I'm not taking it no more. So what can I do? I'm 67, and I don't like taking medication like pain medication because I know ibuprofen is not good for your liver. So, but what can I do? Is it possible for me to do surgery? I'm scared to do surgery, or what can I do? Sir? Ducky? Hello?
Hello, Dr. Buono.
Hello, doctor.
I don't know. Just hold
Time. And then
on.
the pain comes back. That means if you had surgery, you would get better. Some people who have epidural steroid injections for pinched nerves or stenosis, a clogged tube, if they don't get better, well, something else is going on. So the fact that you got better and you've had so many epidural steroid injections, yeah, epidural steroid injections now aren't your cup of tea. Just have a decompression. Decompression, like a laminectomy, is a quick outpatient procedure. But I would need to know what exactly is your condition. There's a bunch of different things that could be attributable to a narrowed tube causing pinched nerve. Is it a disc herniation? Is it the ligament poking out, like that elastic band? Is it a slip of the bone? Is it a big arthritic joint that's pushing on the nerve? But yeah, I've seen patients go through multiple epidural steroid injections. But at some point in time, you are absolutely 100% right. Why would they do another epidural steroid injection if they aren't curing you? They're just making money off you. So, yeah, I would go and find out what's the next step, which would be surgery. But don't be scared of surgery. If that person says you need a fusion, then you need to get a second opinion.
Thank you, Dr. Buono. Can
Yes,
we have
second
your
opinion.
information? Can we have your phone number, your hospitals, everything on the chat?
Yeah, I don't know how to do that.
Okay. You can say it and
uh,
okay.
it's I don't have a card with me. I actually don't know the phone number to my office, but I'm at Capital Health in Trenton. So if you just call the general number there, Capital Health, you can find it online.
Okay.
And you can find me online at Capital Health and just
Okay.
call the office. My office had just changed, so I don't know what the new phone number is.
Oh, and where's your office?
It's at Hopewell in Pennington, New Jersey.
Okay. Hopewell, Burlington. So Dr. Buono's office is Capital Health, Hopewell, New Jersey. Thank you very much, Dr. Buono. I have a question.
Sure.
I just had like L1 fracture, and I did I think kytoplasty.
Kyphoplasty for
Yeah,
compression fracture. Yeah.
kytoplasty. So I'm telling you, that was a life-saving thing that I did. So is there anything I should worry about after that?
Yes. So kyphoplasty is an amazing procedure when you have osteoporosis and you get a compression fracture where your bones are soft, the bone gets squished, causes a lot of pain. They put a little needle into the bone, insert the balloon to make a cavity, and then they inject it with kind of like methyl methacrylate. The guys, what the women use for fake nails. Okay. And that hardens and makes the pain go away. But you're not finished yet because you have to figure out, why did I have the compression fracture? Do I have osteoporosis or osteopenia? You need a DEXA scan.
No,
You need
I
to see an.
fell down. I fell down and I had the L1 fracture.
Yeah, but I've fallen many times and I don't get fractures.
No, this
So,
was a really hard fall, like really hard.
all right, but still, you can't leave it alone. If you fall and
Okay,
get a compression fracture, you need to worry about, do I have soft bones? So
okay.
you need to get a DEXA scan, especially after your age of like 50 or around 50 years old. Get a DEXA scan so that you can prevent bad osteoporosis when you're older. And
I
that's one
did.
sign that you have soft bones.
I did. I get the test already, so I have to. So thank you very much. Do any other person have any question for Dr. Buono? Okay, thank you again, Dr. Buono.
Okay, I'm going to turn this off now. You good with that?
Yes, we good. Thank you very much.
All right, thank you. Take care, everyone.
Um, so we have Dr. Matthew
Blessings.
Toth.
I think I have a question on the chat.
Oh, he left. The doctor left. So
Oh, okay.
yes. So the other doctor is coming on, Dr. Matthew Toth.
Hi, everyone.
Hi, everyone. Like I said before, Dr. Matthew has been working in the physical therapy field for 20 years, and he graduated from Mercer County Community College as a licensed physical therapist since 2002. So after receiving his bachelor's degree from Rutgers University in exercise science, he earned his doctorate degree in physical therapy from University of Medicine and Dentistry of New Jersey in 2010. Dr. Matthew has practiced in almost every area of physical therapy profession, but his passion is in outpatient orthopedic physical therapy. He achieved board certified orthopedic clinical specialist from the American Board of Physical Therapy Specialists. He has worked for Capital Health for the past 18 years and also worked as an adjunct instructor in the PTA program at Mercer County Community College. So thank you, Dr. Todd. You're welcome. Thank you again.
You're welcome. Can everyone see my presentation?
Yes, we can.
Okay. So, it's hard to follow up Dr. Buono because he's an excellent practitioner, and I love referring patients to him when I'm having trouble getting them better because he takes the time, as you can see, to diagnose patients, which is very important. Instead of just doing a random treatment, see what works, trial and error approach. So he went through a lot of the anatomy, so I won't be doing a lot of that. I just want to kind of give you guys an idea of what we do in physical therapy in a general sense and give you some tips on what you should do if you experience back pain. So we kind of went over this. I went to all these schools here and was board certified in orthopedics in 2015. So the one thing I want to talk a lot about without being boring, because sometimes this academic stuff can be boring, is evidence-based practice. And I'm a big proponent of this. Obviously, everything medical practitioners do is not always 100% supported by the evidence, but most of what we do should be, and we should start with that. When we talk about evidence-based practice, it's not just, well, is there a study to prove what I do, and I only do what the studies prove that I do. There's obviously individual clinical experience where I treat patients with certain things, and maybe I've noticed that they get better, so I can bring that in combined with the evidence, and then the patient's values culturally or just generally, and expectations, and we have to meld those together. So we use what are called clinical practice guidelines. They're documents that take all the evidence about a specific disorder, diagnosis, and kind of distill down what the best evidence is, and actually give us recommendations on what the techniques or diagnostic criteria that isn't so great. So our profession, there's a lot of variability. I'm certain somebody in here has probably had a bad experience with physical therapists before. Reimbursements dictating a lot of those issues. And we'll talk about how about not getting personalized care, and the therapist is seeing too many patients at once, or they're just doing massage, or they're just doing a stretch, or but we'll talk about why those things aren't the greatest things when you're seeing a physical therapist. So as far as difficulties with treating lower back pain, Dr. Buono talked a lot about MRI and imaging and CT and nuclear image scan. And those things are very important. However, early on in back pain, except in a handful of situations, an MRI is really not necessary. It's not the only thing that's going to dictate diagnosis or prognosis, meaning, if you'll get better or not. Most people will have those disc bulges that Dr. Buono talked about. And if you go to the wrong doctor, obviously not Dr. Buono, because he said that if it's not touching the nerve root, it's not causing the problem, most likely. You'll be told you have a bulging disc. And the problem with that is psychologically, once you're told that you think that's your problem. And that's why Dr. Buono gets irate patients, because maybe they didn't get to Dr. Buono for another 6 months or to a year. And, they've really solidified that belief. And it's hard to let something go once you believe it. And, we see that a lot nowadays. And, but it's probably not just nowadays, but over 90% of healthy individuals over the age of 60 have bulging discs on MRI. So as a physical therapist, unless you meet a certain criteria with your pain, and we'll talk about that, we're not really concerned with an MRI initially. But every week I get a patient that wants an MRI immediately, and I try to educate them, but you can only reach so many people. Most of the time I'm successful, but we'll talk a little more about that. So like Dr. Buono was talking about, mostly accurate structural diagnoses, meaning that there's a disc herniation, and that's, once we distill it down to that is definitely your problem. And we're going to use a certain set of interventions to treat that issue. However, in the conservative field, it hasn't really held water, so to speak, that like focusing on a structural problem like a muscle strain or a disc bulge or SIJ pain. Those things, they don't really, haven't really helped us guide the best practice. And what we're finding over the years is that this subgrouping method of taking certain symptoms of a patient and kind of clustering those up and putting you in a certain classification of back pain. Specifically, I'm talking about lower back pain, but spine pain in general. The best practice is to start with this approach. Obviously, you have to have red flag screening, and we're going to talk about what that means. So for these studies, they talk about two kinds of pain: acute pain, usually 6 weeks or less, and then everything else was described as chronic. They tried to put a middle category called subacute, which is like between those two, but it's just too much variability. So this is how we kind of start with where we're grouping a patient for back pain. And then we take that acute and we break it up into groups. Acute lower back pain with mobility deficits generally means that there's a loss of motion to the middle or end range of motion of your back. And usually what we're talking about is just localized low back pain, no leg symptoms. The second one is almost the same as the first, except it's where the pain or loss of motion tends to occur more in the beginning when you start to move your back to the middle. Movement coordination deficits would be more like you don't have good control of your trunk, maybe some weakness around the spinal musculature, the core, if you've heard that term. And then we have acute low back pain with leg symptoms. That's basically the sciatica symptom, numbness, tingling, burning down in the leg. Chronic low back pain, it's basically usually at sustained end range movements of your back. It can just be at rest. We do have another category of chronic low back pain with leg symptoms, because you can have prolonged leg symptoms such as like sciatica. So as far as treatment, it's kind of I guess a pet peeve for a lot of physical therapists that we hear at our holiday parties. This hurts, so what can I do to stretch that? And unless we examine you, we really can't tell you. If somebody gives you a stretch and you feel better, they got lucky, because we do a thorough movement-based exam to figure out how we're going to begin your treatment. But essentially, this starts kind of my talk about what should be included in your physical therapy. So if you go to somebody and all they're doing is putting a hot pack on, electrical stimulation, or all they're doing is doing a massage and then a hot pack and electrical stimulation, you're actually being mistreated. Because the bottom line is that all the best evidence shows a combination of those things is the best way to handle a patient with spinal pain. So patient education is actually very, very big. And you could see Dr. Buono starts there. He's not going to just say you need surgery and not explain anything to you. He spends time, educating you in the diagnosis. We do as well. We want to explain, why things might be happening and what we can do to fix them, and kind of calm you down, because back pain is very uncomfortable sometimes. And, if it's not something we need to refer out to another practitioner immediately, we're going to, show you that it's not the end of the world, that the natural history of lower back pain is improvement. And when there's no improvement, there are other things to do for it, including injections and all different kinds of surgical techniques or procedures. So, but we use exercise as our big thing. It's the thing in every subgroup that's included. That involves two kinds of exercise. One could be local exercises for the spine. One could be a big one that shows up is general cardiovascular conditioning. So a lot of times when we have back pain, most people, they don't want to move because it hurts. But I'm a big proponent of, if there's any movement you do that is not increasing those symptoms, then you need to do more of that. That general increase in blood flow, especially for a patient with chronic back pain, is huge. And sometimes you don't realize, if you start slow, like you do a 10-15 minute walk, and then you assess yourself and you see if that causes back pain. And if that goes away, then you're or it doesn't cause any pain, you add a little bit to it. And you'd be surprised at how much you could manage your pain just moving a little more. Modalities, that's just a physical therapy word for anything like electrical stimulation, cold laser, hot packs, cold packs, all those things. We do manual techniques, joint mobilizations. That's where we kind of spring on the joints in your spine, like we kind of push a little bit of an oscillation. And you can actually do what's called the grade 5 technique, which is when we actually will do that end range quick thrust, just like a chiropractor does. I would say that the difference is, when we think that that's indicated, we're much more specific about it. You have to fit a certain cluster of symptoms for that to even be considered. Whereas, not all chiropractors are made the same. Some of them are better than others. But the ones that really spend time diagnosing and then, applying that technique is what you want to see. And then medications. I don't prescribe medications, at least in this state. We're not allowed to. So, but what we can say is that if you don't have any reason why you can't take especially with acute back pain, those anti-inflammatory medications initially can get you back to moving a little faster. But I would always make sure they come from a qualified practitioner. Oops. Let me just do this. Sorry. So, as far as treatment, the first thing, if you've never had back pain before, a lot of people, depending on how you view pain in general, some people have. I just ran into a patient a couple months ago. I've never been in any pain, so immediately runs to the emergency room. Probably didn't need to go to the emergency room. There are a few reasons why you would go to the emergency room, and I'm going to tell you what those are. But if the pain's acute, obviously rest is okay for a few days. You don't want to be like just pushing through, because sometimes you can make the condition worse, like a disc herniation. If it really is, and we don't know yet, you might make it worse by like just continuing to, if you have a heavy job, lifting things, whatnot, and then you can use like over-the-counter stuff like hot packs, cold packs. If you have access to a Tenjin, if you've been prescribed one before, that's a home electrical stimulation device and medications. And the big thing here is just maximizing the things that don't increase the pain and avoiding the ones that do. Okay. So when you're having pain, you got to talk about what things are affecting that. And I like this analogy. Basically, you think of it as a cup that you fill up, and if you have a structural problem in your back, you're stressed all the time, you're not sleeping well, you're sitting all the time, you're filling that cup up and you have no capacity. Excuse me. So
formerly they land for number 30 Ogbeche Street, back of St. Jude Catholic Church, before Okokoro River.
Okay.
Where they land.
So and basically when you fill that up and then you try to do just a little too much, it spills over and you get pain. This includes like psychological issues like anxiety, or all those issues need to be addressed. It actually has an effect on your back pain.
Can you mute that person, please?
Tell us the story the way.
Yes.
Can you hear me?
Your father, I've been your father senior.
Now he's senior, my father's.
Hello?
Yes, there are blessings. Yeah, blessings. Oh, as if that's iPad. Can you mute yourself?
Yes, sir.
And as he joined army,
Sir.
now this time people as they join army, they'll go. Nobody hear from them for a very long time.
Exactly.
They don't come back out.
So basically, if you kind of decrease those things, you can, keep that cup from spilling over, and you're building a better cup by moving more, focusing on your stress, trying not to worry about it enough, getting better sleep, eating better. All those things matter when it comes to pain, because there are certain foods that could be inflammatory. Stress is known to be associated with increased aches and pains, and those things are an activity. If you're not moving your body, which we're obviously as a PT we're big proponents of, you can have an issue there. So it's a good analogy to think about. So if you get back pain and you haven't seen a practitioner, I use this with my patients all the time. If you want to get a more beneficial effect from your initial evaluation with a therapist, start thinking about and maybe even writing down the things that make your pain feel better, the things that make it worse, and the things that are maybe middle of the road, but really the things that make it better or worse. And I'm going to tell you that if you do something and it feels better, or it really doesn't increase your pain, this is that 0 to 10 scale, you should do more of that, because if you are just avoiding everything, you actually could be doing yourself a disservice. But if you do something like, say you sit 10 minutes and your back pain becomes completely terrible, you're getting burning all the way down your leg, you should stop that. You should modify that. Sit less, try to modify your position in the chair, any of those things. So avoiding the things that make it worse, maximizing the things that make it better, and maybe coming to us with a list of those things. It can really help us guide our treatment. So basically, there are reasons why you should skip us and see a doctor immediately. And Dr. Buono kind of hinted at a lot of these things, but here's a little bit more. So if you have severe back pain, 10 out of 10, it's traveling into your leg, especially if it goes past your knee all the way to your foot, especially if the leg is weak, like you're dragging your foot, call that foot drop, where you can't really move your foot well, so you kind of slap it on the ground when you step through. Those are indications, especially if this is a new thing for you. Most likely you want to definitely get seen immediately. Going to the ER wouldn't be out of the question, because they could, in the very least, make sure there's nothing. They're not going to do an MRI, most likely, unless they think it's very indicated. But they could give you like the steroid medications orally and things like that to kind of get the swelling down and maybe start making you feel better. If you get back pain, or you've had back pain for a while, and you get any numbness or tingling in the saddle area, basically the groin area, think of it where the area you'd be sitting if you were on a horse. And that's associated with maybe you lost the control of your bladder or bowel, or you literally can't even, you feel the need to go to the bathroom, but you can't urinate or you can't defecate. That's a medical emergency. It's called cauda equina syndrome. Basically, after a certain point in the along the spine, the spinal cord stops and the nerves flare out, and it looks like a horsetail. That's what cauda equina means in Latin. And those nerves are not spinal cord nerves. They allow you to feel and function in the area of your bladder and genital area. And if you do have that and it doesn't get decompressed immediately, you could be looking at some really permanent nerve damage. So that's definitely an emergency room visit. And if the symptoms don't fit any of these criteria, I would usually say try some conservative things. Like I said, rest a little, try to move around without significantly exacerbating it. Do some of those things. And if it's been a week or 14 days and you don't see any relief at all, you shouldn't wait to see the doctor. I would love if my patients would come to me a lot earlier on. Once your symptoms become much more chronic, they get very difficult to treat, and it could take a lot longer to reverse them. Another one, if you have any fever or fatigue or swelling that you can feel or see, and that's associated with an onset, like if the back pain and that occurs at the same time, you have to get to the ER. You could have a spinal infection. That could be, you could have a paralysis from that. You could end up with a systemic infection, and you could be hospitalized for that. So always never ignore any of these things. The other thing is patients with a history of cancer, over 50, and you have any unexplained weight loss, no relief with bed rest, but especially if you have a history of cancer and you have an onset of back pain and there's nothing you can make it do to go away, it's incumbent that we at least get an x-ray on there to make sure we're not seeing any kind of spread of cancer, because we can't, as physical therapy, we can't treat cancer, and this could be a serious problem. So you have to get to the doctor immediately. All these other things as well, any kind of trauma, don't come to us first. You're most likely going to go to the emergency room anyway. Make sure you didn't fracture anything. If you're a little older and you had a new onset of back pain, you should probably see a physician first. And if you had a prolonged use of steroid medication, because this can lead to weakened bones and very lax ligaments. So you definitely need to get seen by a physician first. So we used to say to do rest, ice, compression, elevation with joint injuries, like if you sprained your knee or something like that. They're trying to get away from that. So now, we do want you to rest for a few days. Like I said, if it's a limb, you can elevate it to decrease the swelling. With the back, I would say just get into a non-pain provoking position. You can take anti-inflammatory medication. However, it's not something you want to do forever unless you've been diagnosed with some type of arthritis and you're being followed by a physician, because contrary to popular belief now, inflammation is your body's healing process, and a little bit of it is good. But if you take too many anti-inflammatory drugs for a long period of time, you're going to reduce that healing response. And it's just the opposite of what you want to do after like a week or so. They do recommend to avoid icing. I would say of everything you could do, icing is probably like the most innocuous. If ice feels good, go ahead and do it. But you don't want to do it every day, especially as that injury matures, because you're just reducing your body's healing response. So then we want to promote the education, and you got to start gradually returning to your activities. So vascular activities like walking, elliptical bike, as long as it's not increasing your back pain, that really can help. If it's chronic and you haven't been, or even if it's subacute, like in a couple months and you still have back pain and you haven't been moving, you got to gradually get back to movement. And then the exercise is obviously what we do. The thing I deal a lot with now too is social media. As you've seen, as I recommended before, every approach that has the best evidence is going to have some kind of exercise component that's active. It's going to have usually some kind of combined manual technique, whether that's some type of massage or tissue release or joint mobilization, and other like activities at reducing your pain or modifying your pain. So the reason I bring that up is when I see these social media posts in general, what I'm saying is that the one stretch that'll cure your sciatica, the one stretch that'll cure your SIJ pain, and it's just not true. It doesn't exist. And if you do feel better with one stretch or one technique that you see online, you actually just got lucky, because most of these people, they're just trying to like promote some kind of product or something like that. So again, any practitioner, anything on social media that says do this and everything will go away, I would not do that unless you don't have the leg pain, any of those red flag symptoms, which are the reason on my slide that you have that says the reasons you should see the doctor. I would, try to get to a physical therapist before. So for choosing a PT, I missed that word. All right. A little tip for patients, because in our field, because our reimbursement is dwindling, a lot of practices will have a therapist have 4 patients at once. And it's just really ridiculous. You're never going to get anyone better doing that. If you do, you're just getting lucky. So I would say if you want to try physical therapy, call the place first. Ask how many patients that individual therapist sees an hour. Because if they see, let's say they see 1 to 2 an hour, that's where you want to go. It's really unreasonable you're not going to find an insurance-based practice that sees 1 an hour. They just would not be able to sustain their business. You might find a cash practice if you have the means that you can get that. And usually if you have out-of-network benefits, you can apply that to that deductible. But the less patients an hour, the better. If you have back pain, you ask if any therapists are certified in the McKenzie system or in orthopedics in general, because, in those cases, you're going to have somebody that actually knows, that's actually going to spend time diagnosing what to do with you, and not just give you like a strap and say, here, stretch your hamstrings, so if you feel like you go to a therapist and your evaluation is rushed, they never put their hands on you, they just talk to you, move your leg a couple times, and then give you some exercises, go somewhere else, because it's not going to work. And if it does, you got lucky. You want a tailored treatment. Okay. There's a lot of alternative practitioners out there. Alternative medicine, complementary alternative medicine is just anybody that's using something that wouldn't be considered a mainstream medical procedure or technique. Things like acupuncture, even chiropractic to a certain extent. Depends on the chiropractor. I'm not going to throw all the chiropractors under the bus, but I do think if I'm going to go individually here, if you feel better when you get acupuncture, then that's fine. If it makes your pain go away, I'm happy with that. I would say keep doing that. Although I'd rather you be doing something where somebody doesn't have to pierce your skin. But as long as it's a clean technique and all that, you should be okay. Massages, it's classic. Everyone thinks physical therapy is nothing but massages, and we kind of did ourselves a disservice years ago with that. But in and of itself, unless something is a very temporary pain from stress or whatnot, massage therapy is not going to cure your symptoms. But it's okay to go to these practitioners. There's certainly nothing wrong with it. The one case I would try to avoid is if you see a chiropractor and you're having localized lower back pain and they want to crack your neck, so they want to do a thrust technique to the joints in your neck, I would walk out of that practice. or tell them not to do it. If he just cracks your lower back, it would be somebody that, you know, maybe has a better idea of what should be done. But you have to remember that, like, everything that a chiropractor does is very passive. And so it's just a manual technique, or it's heat and massage and electrical stim and all that stuff. It's usually that's why you hear about, if you've been or have somebody that goes to a chiropractor, you know, they have to keep going back. You shouldn't have to do that. You know, physical therapy, the thing that we're going to do is we can do those things too, but we want you to be able to manage your lower back pain. I don't want to see you forever. I want you to get better and then be armed with all these tools to get better on your own. So those things, just think about those things. A few resources for you guys. There's a physical therapy journal called the Journal of Orthopedic and Sports Physical Therapy. This link works. I checked it. It's a what we call a perspective for patients. Gives you a lot of what I said, but it's a good like thing that you can download and maybe even print a few out and give out. Like Robin McKenzie created a method of physical therapy called the mechanical diagnosis and therapy. It has to do with repeated motions of joints in your back or neck. And he has a book called Treat Your Own Back or Treat Your Own Neck. I think he has some joint ones too. As long as you're not having any of those red flag symptoms or significant numbness or weakness in your leg, you could pick the book up and at least try to apply some of what he's saying. I've had patients do it and get better. So if you have chronic pain, a big thing that's coming up in that literature is that, and it's not something that every therapist or every patient even wants to discuss, but there's a lot of times there's a fear avoidance, a psychological issue behind that. Not that you're depressed or anxious or losing your mind, but you know, when you've had pain for so long, you tend to see everything through that pain lens. And some of the pain might not even be organic or arising from the body. It could be related to the way you're viewing the pain. And I know that's not as clear as I would like it to be, but essentially, you know, they're recommending some cognitive behavioral therapy, some meditation techniques, and anecdotally, there are patients that get better by adding these things into their program with chronic lower back pain. So we have 2 locations at Capitol Health. I used to be right down the hall from Dr. Buono, but I don't. I see patients from him all the time. I don't. I think they moved his office, but it might still be on one of the floors in there. We have one clinic in Trenton, right by what used to be known as Helene Fould. If you're from Trenton like me, we call it Regional Medical Center now, and that's the number to the outpatient clinic. It's right next door to it on Heil Avenue in Brunswick there. You could call there. All you need is a prescription, and then we'll get your central scheduling. We'll get you on the schedule, and we'll get going. And then I work at the main hospital at Hopewell, and that's our number there for our offices. So these are just references. I know I didn't go into anything specifically. Like I said, you know, it really depends on what kind of back pain you're having. So if anyone's hoping for me to tell you a couple exercises, you know, I'm not able to do that today. But I hope this was at least educational about how to get the therapy and a little bit of tips on how to choose a better situation and when you should definitely be going to the doctor. So does anybody have any questions?
Yes, thank you, Dr. Toth.
You're welcome.
I have one question here that says, or maybe I don't know if that's for Dr. Buono.
Yeah.
Is active
Hello?
No. Hold on, please.
Yep.
Okay, it says, can you have sciatic pain and SID simultaneously?
Well, so I think that was for Dr. Bono, but I can comment on that. So the SIJ pain, when your sacroiliac joint is the problem, physical therapists have a set of tests that we get you, that we do on you to prove. That was just one of the tests that Dr. Bono showed you, the Patrick's test, or we call it the Faber test. And then if you meet certain criteria, then you have SIJ pain. If you have leg pain, or what most people call sciatica, it's usually not associated, it's not arising from the sacroiliac joint. There's the nerve goes by there, but it's not, there's nothing at the joint itself that's going to impinge on that nerve root. So you could have a problem that's pinching your nerve and SIJ pain. And if you have both of those things, then, you know, I would say of the two things, you got to get rid of that leg pain. But you could also not have SIJ pain, and that pain in that area could be arising from a joint issue, like the facet joint issues that Dr. Bono was talking about. And it could be irritating a nerve, and it feel like you have both of those things. But the leg pain is more concerning. If you have numbness or tingling down your leg that goes past mid-thigh, I would say, especially if it doesn't go away and it's constant, you got to get that treated. You got to start getting treatment on that, because usually there's some kind of nerve involvement there. So I hope that was a good answer for you.
Thank you. Any
Yes.
question?
Yes.
Go ahead. Yeah.
Thank you, Doctor,
You're
for the
welcome.
teaching. I understand that vigorous ROM can cause too much joint pain.
Mm-hmm.
Can you please explain what causes back heel pains, and how can we prevent that, which is not associated with prolonged sitting or standing?
Oh, I see. Yeah. As far as prevention of back pain, it's the same recommendations in general as prevention of most pain anywhere in the body. You know, I won't sound like your typical physical therapist and say you have bad posture, you sit too much. It's just that because of the way we live our lives, especially, in offices and sitting a lot, that's why we sit a lot. So if you were in the military and you were always standing at attention, standing up, you would have a different cause to your back pain, and you'd be standing too much. So as far as sitting, you're sitting too much, that's definitely what causing your pain. I would say the best thing you can do is to promote an active lifestyle. So,
Doctor, I mean the back of a heel pain.
The back of the heel?
Yes.
Like in your foot?
Yes.
Yeah. Oh, okay. Well, we were talking more about lower back pain, but if you have pain in your heel, and it's isolated to your heel, that could be a whole different issue. That could be a heel spur, which is a little bone deposit from rubbing of the tendon, or it could be plantar fasciitis. There's no real prevention there per se, unless we can figure out exactly why that caused that. Usually patients with that have a job or a lifestyle where they're on their feet a lot, maybe walking a lot, maybe even you're a runner, and you're running a lot, and you start developing that. But some things I might try before you go to a doctor for heel pain would be like switching your footwear. Most people don't realize, like, if you're walking a lot or standing a lot, you should be switching your footwear every 6 to 9 months.
You think if you like a nurse, that could cause a heel
Oh
back?
yeah. Oh yeah. I mean, you can have a pinched nerve anywhere along your leg that could cause pain in the back of your foot. However, when we're trying to differentiate whether it's coming from your lower back or isolated to some nerve by your foot, I would say if you have no pain in your back and no nerve symptoms, if the leg's up here and you have no nerve symptoms anywhere above that and it's all isolated to that heel, then it's less likely to be your back. But in a chronic pain situation, it could be coming from that. So basically, have to do a physical exam and see if we can relieve that with like examining your back, or if we do something with your back and you feel the pain more in the heel, it totally could be coming from that.
Okay, thank you.
Thank you, Dr. Toth. Any other question? Okay. Thank you again, Dr. Matthew Toth.
No problem.
His office is in Brunswick Avenue, Ellingford, or maybe Hopewell, Capital Health. And Dr. Buono too is in Hopewell, Capital Health.
Yep.
So we put some information. The phone number to be reached to call for appointment is 609-537-7300. So Dr. Buono and Dr. Toth, thank you very much for the education.
You're welcome. Yeah. Thank you for the opportunity. I appreciate it.
Thank you very much. We really learned a lot from you.
Thanks. Yeah. Okay. So I'll say is if you have any questions, please let us know. And if you're in the area, be happy to treat you. Okay. All right.
Thank you.
You're welcome.
Okay, thank you. So this is Eko Club Philadelphia. We're a non-profit organization, and this is we give back to our community. We are associated with Home Front. We give back to school. We do back to school program. We give free turkey during Thanksgiving. We give scholarship to high school seniors, and we do go to Ronald McDonald's in Philadelphia to volunteer, and we donate to them too for the terminally sick people. So thank you very much. And Eko Club International, we are associated under the umbrella of Eko Club International, and we are having our 25th anniversary in September, from September 18 to September 21st in Newark, New Jersey. If you need any information, our PRO already gave out the information. So thank you very much, everybody, for coming. So if you have any other question, you can contact me. My name is Olabisi Okoya at 609-638-3297. Or if you have any topic that you want us to get, we can find a doctor to do it. Thank you very much again. You all have a nice weekend. Enjoy the rest of your weekend and have a nice evening. Thank you.
Thank you so much, Honorable Koya and Eko Club Philadelphia.
Thank you.
For this wonderful, very educational, very interactive presentation. You guys are just rock it. Thank you very, very much. God bless you more.
You're
and
welcome.
keep up the good work. Very appreciative. Thank you.
You're welcome, Honorable Alowunde.
Thank you so much, my Honorable Koya.
Thank you, Ma. Thank you very much, Ma.
Thank you so much. I really appreciate it.
Thank you.
And thank you for including me.
Thank you.
Yes.
Yeah,
This is from Canada.
Yes.
Yes. Thank you.
Very much.
Yes.
God bless you, ma.
Bless you all.
God bless you.
Yes.
Thank you.
It's really good. It's really,
Blessing,
really help.
everyone.
It's really help.
Honorable Conrad.
Yes, ma'am. It really helped. Shima.
Yeah, I guess
God bless you.
everybody, like almost everybody, have back pain.
Yeah, yeah, standing
Hope we learn
at
from it.
job, sitting. Oh God.
Yes, thank you very much.
Shima.
So if you have any topic, you can send it to us. We try to get